Okay. Hi, everyone. I'm Jacqui Butler. I'm an A&E consultant at King's College Hospital in Denmark Hill in London, and one of our mental health leads. My colleague is happily on this session as well. I've been given the somewhat dry topic of search policies to have a chat about. Thankfully, we had a fairly exceptional member of our security team who is all over all the legal bits and bobs to do with this and has written a very detailed search policy, which I believe Barbara had sight of at some time, hence why she came knocking on my door. So if anyone wants me to share any of those documents after that, that won't be a problem. I'm going to look at searching of patients. Our policy includes searching of non-patients and also searching of staff, which is interesting to consider. But we're only going to look obviously at the patients, and that includes mental health patients as well as those who don't obviously present with mental health concerns. The principles are more or less the same. It was really hard to find any numbers about how many patients are searched in the NHS. I certainly couldn't find anything easily, but I did tap the shoulder of my security friend who was able to tell me that in January of this year, they conducted 25 searches within the emergency department. 17 of them were with consent, and they found 14 items, which included knives, broken glass, razors, scissors, knuckle dusters, a hammer, and like a Swiss Army knife kind of tool, among other things that could be considered dangerous to the patient or to other people. So it's something that we're obviously doing relatively commonly within our department. Oh, how do I advance my slides? Sorry. So I'm just going to really quickly touch on when should we consider searching a patient? Are there any legal frameworks that we need to consider in doing this? Obviously, doing it with consent versus not with consent. Are there any special considerations for mental health patients? How do you actually search someone? And then just very briefly mention the variation that our pediatric emergency department have in their patient search policy. So when is it okay to search someone? Basically, you have to have a genuine belief, which is actually based on some reasonable suspicion or grounds that they actually possess a dangerous, prohibited, or restricted item which could cause themselves or someone else harm. And the reasonable suspicion or grounds is based on direct observation of behaviors or actions or words. It might come from information from another source, such as a patient going up to one of the members of staff saying, I think that person's got a knife in their pocket. And obviously intelligence stuff that might come from police services, sometimes LAS, or perhaps previous experience with some of these patients. We certainly have people who have special cases on their file because we know they are known to carry weapons and things like that. And that should prompt us to consider whether on this occasion, a search would be a reasonable option to take. So dangerous and prohibited, you probably can work all these out for yourself, but sort of offensive weapons, the most common thing we would see would be knives, but obviously guns, explosive devices, any sharp objects which could be used to harm yourself, drugs of various sorts, both the illicit kinds, but also remember prescription drugs might be a method of self-harm for patients who are presenting with suicidal thoughts. So someone with that whole box of amitriptyline in their pocket or something might be a reason on which you would consider searching them. Solvents, obviously alcohol, lighters and the fluid that goes along with lighters, and then things that could be used as a ligature, so cords, twine, etc. There's several legal issues that can be considered in how we might implement mostly the non-consensual kind of search. So Mental Capacity Act, including deprivation of liberty standards, Mental Health Acts, Human Rights Act, you have to consider Equality Act, and sometimes common law can play a role. The bottom line is that as much as I can't walk up to someone on the street and say, excuse me, please turn your pockets out because I want to know what's in them, I also have no legal authority to do that to a patient within my emergency department without their consent, except in specific circumstances. So you are potentially opening yourself up to civil or criminal charges if you lay hands on a patient to search them without consent or without an appropriate legal backing of your actions. And it's also worth bearing in mind that coercion is considered unlawful or can be considered unlawful. I think there's a fine line in potentially bargaining with a patient. So some people might argue you only let them go out for a cigarette if they agreed to a search. but we know that there's lots of things that you can use in bargaining. So that's just something to bear in mind. But certainly threats of withholding basic care or anything like that, or disclosing personal information to get someone to be searched, would definitely be out of bounds. We all know that law enforcement agencies such as the police, the prison authorities, border agencies and things have a whole different set of powers that they can use. And some health authorities, including mental health trusts, do have some different regulations, but the premise is the same. They have to have a reasonable belief that someone is actually concealing something that could cause harm to themselves or others. You can't just willy-nilly search people without any basis. A consensual search. The first part of that should actually be not having a search at all. It should just be a discussion with the patient. Do you have a packet of tablets? Do you have any sharp objects? And ask them, and hopefully they'll agree, and hopefully they'll hand them over to you, and then there's no need to even broach a formal search. But if you are going down that road, what you have to do is explain fully to the patient why you think you want to search them, what you're looking to find, and how that process will go. It should be explained to them that so if they do consent to a search, but halfway through they change their mind, they're allowed to change their mind, and you have to stop the search at that point. You should ideally have 2 team members present when you're gaining consent for this. Sites that have body-worn cameras, you might use those as well, but there should still be 2 real live people in the room. Consider the gender of staff, obviously relevant when you're conducting the search, but also should be considered when you're asking to do the search. Ideally, staff should have received training. I know our security team get training on this. I'm not aware of any training for clinical members of staff beyond an awareness of the policy. You should consider privacy and dignity as best you can. And that's not just for the search process, but ideally you don't want to stand in a corridor surrounded by patients on chairs and tell someone that you want to search them for this particular reason, because that's a breach of their privacy as well. And it goes without saying that everything has to be recorded in patient notes, and our security team, whenever they go hands-on, would record it in the DATIC system. In a non-consensual search situation, so your patient has refused to disclose if they have anything, they've refused to let you search them, but for whatever reason you feel quite compelled that they actually need a search to make sure there isn't something. First question you should ask yourself is there anything else I can do? And this is one thing where our pediatric colleagues vary from the main policy, in the sense that if someone doesn't give consent, except in the most extreme circumstances, their default is give them one-to-one direct continuous observation. Now, that might not be appropriate if you have a genuine belief that there is an offensive weapon in the pocket of the patient, because actually what you might be doing is putting that person doing the observation at risk, and that's not ideal. But you certainly should consider that, because all of this, when you're coming to the non-consensual side, like everything else, is done in the framework of the least restrictive option and the least sort of imposition on someone's human rights. So can I just have a RMN sitting with the patient, directly observing them, such that if they reach for a packet of pills, we can intervene? If you've decided that there isn't a safe option that doesn't involve avoiding a search altogether, probably the most common way it would occur in an emergency department is using the Mental Capacity Act. Like any other treatments or interventions that we do, if we feel that they are necessary and essential, then if a patient cannot demonstrate capacity to accept or decline that, then we can use the Mental Capacity Act to actually carry out a forcible search on the patient. Obviously, that assessment must be clearly documented in the notes. Restraint and physical interventions can be used to conduct a forcible search, but much like in any other scenario, this should be the last resort. There should be an appropriate legal framework backing up the process, and it should occur for the shortest time possible in all the principles of least restrictive. And I think it goes without saying that if there is a serious concern about especially offensive weapons, or if there's some debate amongst the team about do we have a legal framework to do this, the police are on the end of the phone. And also, if you don't have an in-house security team that will do this sort of thing, then consider calling the police, because they will definitely come and help you out in that setting, I hope. It's worth mentioning that in the Human Rights Act, there is a provision that does allow you, it has been used in case law, to forcibly search someone who does have capacity to decline that search, but you have to be able to demonstrate that it is reasonably necessary and it is proportionate to protect other people from the immediate risk of significant harm. So it probably doesn't apply if someone's got something in their pocket that they're perhaps going to overdose on. But if you think they've got a gun and they're expressing homicidal thoughts and there's a room full of people, then you can possibly use that to override someone's actual capacitous decision to decline being searched. Mental health patients, are they any different? Not really. Anyone who's informal is the same as any other patient in your emergency department, and you need consent to search them unless you meet other criteria. There are provisions under a completed Mental Health Act section that you can search people, but again, you have to have the basis to do it. You cannot just willy-nilly search every mental health patient who's sectioned. In our EDs, this is most likely going to be people who've been brought to us from mental health institutions with their completed Section 2 or Section 3. It may be that if you have people who are sectioned to your acute trust because they have concomitant physical health needs, that would apply. And then obviously the other big group we have are Section 136s, but occasionally you'll get Section 135s brought in by the police as well. Obviously, police have the power to search. In our department, and usually it's our security who are very good at remembering to do this, but if at the point at which we are going to take that responsibility from the police and the police are going to leave, they will always ask about, are there concerns about carrying any weapons or other things? Have the police actually searched them? And they will usually prompt the police to search the patient before they leave if that hasn't been done, just so we have the surety of knowledge that they do not have anything with which they could harm themselves or other people. It becomes confusing, a bit like we were referring to in questions after Mark's talk, that if the section is not completed, so you've got your first and your second rec, and you're waiting for that magical fairy mental health bed to appear somewhere so someone can sign on the dotted line, then you are not covered by the Mental Health Act. You should then consider, can I apply the Mental Capacity Act in this situation? So as we all know, in keeping them in the department, that can get a bit fuzzy, but that's how you could potentially apply that as well. How do you actually search? Bit like the, free massage you sometimes luckily get on your way to the plane when you're going on holidays. It should be a minimum of 2 staff. Ideally, they should be clinical, but in our department, it more often happens to be led by security, but with a nursing or medical team member in the room. It should be gender appropriate. Women should be searched by women, etc. It should happen in a private space, except in the most extreme situations where perhaps someone is kind of being restrained on the ground and there is a real belief that they've got a knife tucked down their socks or something like that. It should really happen in private. You should ask them first if they have anything and can identify where it might be. You ask the patient to empty their pockets, open their bags, hats, shoes, etc. Shake their hair if you think their hair is such that something could be concealed in it. And then essentially it's run your hands along the limbs and torso. It's over the clothes. It's not under the clothes, because once you remove clothes, it becomes an intimate search. Obviously not breasts in women, but we do have to bear in mind that there are people who will conceal things like razor blades and what have you inside their bras. So that's a consideration. And then that would be done ideally with a female team member with full explanation to the patient of what you're doing and why you're doing it. And then the thing to remember is that either accidentally or deliberately, people can drop things onto the floor and knock them under sofas and things, thinking no one in the room will notice, especially if they're small items. So make sure you look around the space when you finish the search to check that that hasn't happened, in case someone's going to pick something up later on. Just finally, to touch on our pediatric pathway, essentially in some data they had 2019 to 2020, they had 1 episode of self-harm occurring or being carried out by a young person within our department, compared to 21 to 22, they had 14 episodes. So we're seeing an increase in it, and that's clearly multifactorial, and it's not something I have to explain to anyone on this call, but it is something that's very front and center in our minds of how to keep these young people safe. Essentially, it is definitely led by clinicians, primarily pediatric nurses would do all the searching. They essentially, if someone doesn't give consent, then it's one-to-one supervision, unless they are very concerned about the nature of the object that might be concealed, or obviously a scenario in which a patient has self-harmed, and then we need to make sure that they haven't got any other implements upon them to do it again, in which case they will escalate to security and clearly the senior decision makers to get a plan about how to proceed. But they're very much more proactive in gaining sort of the one-to-one supervision approach rather than coming across sort of forcibly searching children and young people. And that is a whistle-stop tour of how to search people in the emergency department. Thank you.